Hello students. So in the series of hydrocephalus case management for VP shunt procedure, now we will talk about investigations, what investigations are asked for VP shunt procedure. CBC, ESR, KFT, serum electrolyte, especially sodium potassium, because these patients are on mannitol, acetazolamide, or diuretics like furosemide. So there may be chances of dyselectrolytemia. So this investigation is very important. Urine microscopy, chest x-ray, or 2D echo. 2D echo is not called for every case, but if there is association with the congenital anomaly or there is ECG which is showing arrhythmia, then we can ask for the 2D echo. CT skull, it is a confirmative diagnostic tool where bilateral massive enlargement of ventricles and displaying of sutures, cortical thinning are seen. Lumbar puncture can confirm raised ICP and relieve it temporarily. It can be done in a communicating type of hydrocephalus. If surgeon asks for MRI, MRI can show periaqueductal cerebellar tumor or Chiari malformation. Skull radiography is not recommended always, but if it is done, then it will show erosion of sella turcica. If baby's condition or patient's condition is poor, we can ask for ABG, because poor condition means if there is repeated vomiting, there is hypovolemia, there is altered mental status, so we can ask for ABG analysis before surgery. During fundus examination, there is papilledema, though it is difficult in infant, but it can be done in the older children or adult or in cooperative patient. USG skull, it can be done by pediatricians or radiologists. In infants, it will show subependymal or intraventricular hemorrhages. Transcranial Doppler, it is non-invasive tool, but it is rarely used. During CT scan, we can see two indexes which are very important for the examination purpose. First is Ivan index, maximum width of the frontal horn of the lateral ventricle divided by maximum inner diameter of the skull at the same level, and it should be more than 50% is indicative of hydrocephalus. The second index is ALVI index, antero-posterior diameter of lateral ventricle index. It is also seen during CT imaging, and it is maximum antero-posterior diameter of frontal horn of lateral ventricle divided by maximum inner diameter of skull at the same level, particularly useful in the normal pressure hydrocephalus. Talking about the medical management, diuretics like furosemide is prescribed, acetazolamide, mannitol, anti-epileptics, steroids, but all these drugs, they have a little role in the management of hydrocephalus. Important point is to be noted, choroid plexus secreting CSF has many ion pump and enzyme which is similar to renal tubules epithelium. Hence, acetazolamide and furosemide is used to limit the production and promote secretions of the CSF. What is the disadvantage of using these furosemide or acetazolamide? It will cause electrolyte disturbances. This is very important. We should always ask for the medication which is going on during the treatment of hydrocephalus, and it is very important we have to ask for these drug therapy during PAC. Spinal tap is indicated only in communicating type of hydrocephalus. It is contraindicated in obstructive hydrocephalus. So what are the surgical management options? Choroid plexotomy, external ventricular drainage, endoscopic third ventriculostomy, and the shunt procedures. Shunt procedures are commonly done, and this is CSF diversion procedures. And during shunt procedures, actually the tube is inserted into the lateral ventricles, and after cannulating the ventricles, the subcutaneous tunneling of distal portion of shunt, and the other end of the shunt is inserted into the peritoneal cavity. This is called ventriculoperitoneal shunt, and this is the what is the most common VP shunt? It is Chabra shunt, which is a spring loaded shunt. It is commonly asked question in the viva. The second one is a ventriculoatrial shunt, but significant risk of air embolism is there. Ventriculopleural shunt, other is lumboperitoneal shunt, which is done in communicating type of hydrocephalus. Ventriculocisternal shunt or Torkelson shunt, which is done in the non-communicating type of hydrocephalus. The thecoperitoneal shunt. The most important question is anesthesia challenges, which is faced by anesthetist during the induction of the infant or when we prepare the baby for the VP shunt procedure. Okay, the first one is age, newborn or infant. If the patient is newborn or infant, it is very high risk case. And why it is high risk? Because there is immaturity. And the second high risk point is also prematurity, because there is prematurity in cardiac function, there is prematurity in lung function, the brain function. We already know in infant or premature units there is heart rate dependent cardiac output, there is hypotension, there is because there is contractility is low, stroke volume is low, cardiac output is low, and there is high chest wall compliance, but there is lung compliance which is already reduced, FRC is less. Okay, so these are some high risk physiological points. Some anatomical points are also high risk. Okay, so sedative pre-medication is contraindicated. Why it is relatively contraindicated? Because it masks the signs of neurological dysfunction, because of sedative pre-medication the baby can sleep, so there is sleepiness, so that will cause hypoventilation and it will cause hypercarbia or hypoxia, it will lead to raised ICP. So what we do to calm the baby, if the baby is crying, so what we should do, we can give oral dose or intranasal midazolam, it may be considered. Okay, we have to calm the baby, otherwise there is harmful elevation of ICP again. Okay, then third point is emergency surgery is much more high risk than the elective surgery. Definitely it is, because in emergency surgery baby may come with the full stomach, or there is they come with the pulmonary aspiration, and during emergency surgery there is much more rise in the ICP, there is neurological deterioration. Okay, so careful monitoring of baby during pre-op period, also pre-op period is also must, because there can be chance of rapid neurological deterioration. Suppose respiratory arrest or unconsciousness occur preoperatively, because there is already raised ICP, or suppose there is tonsillar herniation occurred, so immediately ET tube intubation and hyperventilation with 100% oxygen should be carried out, and preparation for urgent ventricular tap should be done. Okay, then the poor general condition, babies are from low socioeconomic status, are also with the poor nutritive status, or because of the repeated vomiting, or because of the poor appetite, there is poor general condition, malnourishment can be there, unconscious baby will be presented, and respiratory distress, anemia, aspiration of gastric content, association with the other congenital anomaly like vectoral group of anomaly, neurological deficit, severely raised ICP, cranial nerve palsy, recurrent seizure, repeated projectile vomiting or poor feeding. Because of the repeated projectile vomiting, there may be chances of dehydration, intravascular volume depletion, and dyselectrolytemia. Infections, if there is infection, meningoencephalitis or respiratory tract infections are there, then we will optimize the baby first, and we give antibiotics. Because the baby is of hydrocephalus is having large head, so position is difficult. Proper position is very important during the pre-oxygenation or induction of baby. Head for that, head portion of the OT table tilted slightly downward, and a ramp was made up with the rolled tablecloth and placed below the shoulder to elevate the baby body, and again the head ring is kept below the head of the baby to prevent it from falling sideways, right? Because surgery is done in the supine position and head turned to the opposite side, and the head flexion may aggravate brain stem ischemia. Okay, so we have to avoid it. Anatomical factors associated with the newborn or infant can pose problem of difficult mask ventilation or difficult intubation, because anatomical factors like chubby cheeks, small nasal openings, small oral opening, large tongue, large epiglottis, the larynx is more anterior and cephalad is there. So it is, these are the anatomical factor, large head, these are the anatomical factor which can pose problem with mask ventilation or intubation. If there is already rise tube is present, it will lead to respiratory distress in infant because they are nasal breather. Newborn and infant up to the age of 5 months, they are obligate nasal breather. Susceptibility to hypothermia, we have to maintain the OT temperature or the baby temperature by using the blowers or warming blankets. We have to give warm fluid if there is more, they are more prone for the hypothermia. They have a difficult IV cannulation, less FRC, so rapid desaturation during the period of apnea. We have to keep this into the mind. More chances of upper airway obstruction under anesthesia. We have to maintain cerebral perfusion pressure until the raised ICP is relieved by putting VP shunt. Avoid hypotension as and cannulating the ventricles. BP may drop abruptly as brain stem pressure is suddenly released. Avoid bradycardia also, avoid hypothermia also, avoid hypotension also. Maintain normocapnia or mild hypocapnia. Aggressive reduction of PaCO2 increases the risk of brain ischemia, so it is not recommended. Avoid any increase in intracranial pressure, like we have to choose anesthesia agent very carefully, like we have to use thiopentone, propofol, because they are cerebroprotective agent. Though propofol is not recommended up to the age of 2 years, so we can use thiopentone. If we want to induce baby with inhalational, sevoflurane is preferred over the other agent. We have to keep in mind, we have to do smooth intubation, because there during intubation the stress is produced by laryngoscopy, and that will cause more rise in the ICP. We have to avoid it. Hypercarbia, we have to avoid it, it will again cause ICP rise. Slight head up position, it will cause ICP to lower down. Avoid excessive fluid and avoid hyper and hypothermia. Mannitol and Lasix. Okay, we can give Lasix and mannitol because it will reduce the um, ICP, and keep PEEP minimized. In the next class, we will discuss about the management part of the hydrocephalus posted for the VP shunt. Thank you.